Hello, my name is Angel Stachnik, and I am a senior epidemiologist with the Office of Epidemiology and Disease Surveillance with the Southern Nevada Health District. In this presentation, I will be providing you with an epidemiologic profile of HIV in Clark County. We will be looking at new HIV diagnoses by county, race, sex, and age. Afterwards, I will briefly go over statistics on persons living with HIV in Clark County. Lastly, I will provide some statistics on HIV and STD co-infections.
My name is Cheryl Radloff, and I'm a senior health educator with the Southern Nevada Health District's Office of Epidemiology and Disease Surveillance. I'll be discussing some of the sociocultural issues associated with HIV epidemiology.
New HIV infection rates by county. The first slide shows new HIV infection rates by county for the last 5 years. Rates are expressed as per 100,000 population and are calculated using the Nevada State Demographer's estimates and projections. Clark County has the highest rates of HIV in Nevada. However, the rates have been relatively stable over the last 5 years for Clark County, as well as Washoe County and the rest of the combined counties in Nevada. Overview, 2017 new HIV diagnosis. This slide gives you an overview of 2017 new HIV diagnoses. There was a total of 486 new HIV diagnoses made among Nevada residents in 2017. 439 of these cases were diagnosed among Clark County residents. Clark County residents represented only 73% of Nevada's population, but accounted for 90% of Nevada's new HIV diagnoses in 2017. This shows that Clark County bears the majority of the disease burden. Also, racial disparities are evident as well. While blacks accounted for only 11% of Clark County's population, they accounted for 32% of new HIV diagnoses in 2017. However, whites represented 46% of Clark County's population, but only accounted for 32% of new HIV diagnoses in 2017. New HIV diagnosis by race. Next, let's look more closely at the number of new diagnoses by race in Clark County in 2017. Overall, in terms of case counts, there was a 14% increase from 2013 to 2017. However, we saw a 4% decrease from 2016 to 2017. When we break this down by race, we see that white, black, and Hispanic populations have the highest case counts. For whites, there was a 10% increase from 2016 to 2017. For blacks, there was a 36% increase from 2015 to 2016, but a 12% decrease from 2016 to 2017. Up until 2016, Hispanics and whites had higher case counts than blacks. For Hispanics, there was a 6% decrease from 2016 to 2017. For Asians and Pacific Islanders, or API for short, there was a 40% decrease between 2015 and 2016, but a 19% increase from 2016 to 2017. New HIV diagnosis rates by race. In this slide, we are looking at rates of HIV per 100,000 population by race from 2013 to 2017. Blacks have the highest rate. The rate among blacks was stable from 2013 to 2015, but increased 32% from 2015 to 2016. It appears that the rate decreased from 2016 to 2017, but this was not statistically significant, meaning that the decrease is just a random blip and not meaningful. Hispanics have the second highest rates, although the rates have been stable for the last 5 years. Although whites have as many cases or more cases of HIV compared to blacks and Hispanics, depending on the years, blacks have the highest rates. Like Hispanic rates, white rates have been stable from 2013 to 2017. Asian Pacific Islanders have the lowest rates overall, with highest rate in this group occurring in 2015, but no significant change has occurred for the last 5 years. Again, it is clear that racial disparities exist in southern Nevada.
Why are African American rates of HIV so high in Nevada? The previous slide shows that racial disparities in HIV diagnosis in southern Nevada is evidence. Many people wonder why racial disparities exist among new HIV diagnoses, especially among African Americans. What we're going to do right now is take a few moments and try to answer the question, why are African American rates of HIV so high in Nevada? There are several responses given. So we're going to begin by clicking on biological factors. So while this is a good answer, we do see that concurrent STIs or sexually transmitted infections and lower rates of male circumcision may contribute to higher HIV morbidity in African Americans. Let's try again to see if we may find a better answer. So let's click on lack of access to medical care. Again, this is a good answer. We do see that with income or socioeconomic status, place of residence, transportation, and availability of culturally competent providers, these may all factor as to why some populations utilize health resources less than others. So let's try again. Let's click on distrust of health authorities. Again, this is a good answer. And the picture shows an example of folks' distrust of the medical professionals, and that's a picture of the Tuskegee syphilis experiments. So trust in public health efforts is questioned by many African Americans due to a legacy of ethically wrong activities, and just as mentioned, the Tuskegee syphilis study. So let's try again. So the next choice is homogamy or assortative mating. So let's click on that. Again, this is a good answer. When HIV rates are high in certain ethnic groups, homogamy, or relationships between those who are culturally similar, impacts the higher probability of being exposed to HIV. So let's try it again. All right, let's click on all the above. All right, this is the best answer. So all of the above. So as we saw, all of the factors contribute to higher rates of HIV among African Americans in Nevada, but also in the United States overall. Please watch the CDC video for more information. These ideas are discussed both in the Fundamentals of HIV e-learning module as well as the Linkage to Care module, but this video should give you more information.
While we each have a personal responsibility to protect our own health, we must also tackle the root causes that allow HIV to flourish in African American communities. In fact, many of the same social and environmental factors that place African Americans at risk for chronic diseases, such as heart disease and diabetes, also place them at risk for HIV. The greater overall prevalence of HIV in Black communities means that African Americans face a greater risk of infection with each sexual encounter. The socioeconomic issues associated with poverty, including limited access to high-quality health care, housing, and HIV prevention education, directly and indirectly increase the risk for HIV infection and affect the health of people living with HIV infection. Lack of awareness of HIV status can affect rates in communities. Transmission most often occurs from persons who are not aware of their status. Stigma, fear, discrimination, homophobia, and negative perceptions about HIV testing can also place African Americans at higher risk. We must stop the spread of HIV in the African American community. On this National Black HIV/AIDS Awareness Day, we have more tools than ever to win the fight against HIV. We are seeing great scientific breakthroughs and successes. For example, research does show us that when HIV-positive persons take HIV medicines early, they not only significantly improve their health, but also can reduce the risk of passing the virus to another person by 96%. At CDC, fighting HIV among African Americans remains a top HIV prevention priority. We need your help in keeping the dialogue about HIV front and center. We must talk openly about HIV, confront the root causes of HIV, and get involved in the fight against HIV. Everyone and every action counts.
New HIV by sex and select race. This slide shows new HIV diagnosis by sex at birth and select race. The blue bars on the graph represent males and the orange bars represent females. Males in general are disproportionately affected by HIV regardless of race. Black females have the highest proportion of new HIV diagnoses among females of all races, while Hispanic females have the lowest proportion of HIV cases reported among females of all races. New HIV diagnosis among females by select race. This slide shows the number of new diagnoses by select race. Although the number of female cases are much smaller than males, it is still important to monitor for any increases. We can see that the case counts for Black females almost doubled from 2013 to 2016, before dropping in 2017 to levels seen before 2016.
A note about sex. Sex in traditional epidemiological practice refers to the sex category a person is assigned at birth. Usually the terms used are male and female. Other terms such as intersex or disorders of sex development are naturally occurring variations in humans. Some intersex people have ambiguous genitalia or internal sex organs, such as a person with both ovarian and testicular tissues. Other intersex people have a combination of chromosomes that is different than XY or male and XX or female, such as XXY. And some people are born with what looks like male or female genitalia, but their internal sex organs do not correspond. It is estimated approximately 1 in 100 individuals in the United States is intersex. This is important for epidemiological data because traditionally when we collect demographic information about the sex of folks at birth for individuals who are newly diagnosed or living with HIV, it tends to be in binary categories of male or female. A note about transgender. Transgender is a term for people whose gender identity or expression is different from their sex assigned at birth. Gender identity refers to a person's internal understanding of their gender. Gender expression describes a person's outward presentation of their gender, for example, how they dress. Transgender women describes people who are assigned a male sex at birth but currently identify as women. Transgender men describes people who are assigned the female sex at birth but currently identify as men. There are also some people who may identify as genderqueer, gender fluid, gender non-binary, and other identities. Some common ways that medical records and other public health data refer to transgender folks are transgender female to male, or F to M, or transgender male to female, or M to F. The best practice is to ask folks how they identify.
New HIV diagnosis transgender. The Nevada Division of Public and Behavioral Health HIV Surveillance Program started collecting current gender in 2010, but it was not consistently captured until about 2013. This slide shows the 5-year aggregate, 2013 to 2017, of new HIV diagnoses among persons identifying as transgender. Overall, there were 56 new diagnoses among transgender individuals over the last 5 years. 52 male to female and 4 female to male from 2013 to 2017. Almost a third of this group were Black, 29% were Hispanic, and 25% were white. Asian accounted for 5%, and American Indian and Alaskan Native accounted for 4%.
TransPrEP, HIV prevention for transgender persons in California. As the previous slide showed, while current numbers of new HIV diagnosis among transgender individuals may not be as high as other populations, the numbers are still concerning. One of the prevention strategies that has been recommended for folks is PrEP, or pre-exposure prophylaxis. Further discussion about PrEP will be discussed in the e-learning modules, Fundamentals of HIV, as well as Linkage to Care. As you can see in this video, it is very important that we offer tools for a variety of clients in a variety of communities to reduce risk for acquiring HIV.
I found out one of my partners had had sex with multiple people unprotected, and I wouldn't have known had he not mentioned it briefly after we had unprotected sex. And it's up to me to protect myself.
PrEP is a new HIV prevention method that has been shown to be safe and effective for preventing HIV. And it involves taking a daily pill called Truvada, which has been shown to be highly effective for HIV prevention. Unfortunately, uptake of PrEP in the trans community so far has been fairly low. And we think that this is because a lot of the marketing around PrEP has been focused on gay men and not transgender individuals.
It's estimated that 1 in 4 of us in this country are living with HIV. That's trans women of color. For African American women, it's over 50%. And that's just unacceptable.
We were hearing from the community that what was really needed was a project that focused only and specifically on the transgender community. And so we put together an initiative that we are funding across 3 projects in California, 2 in Northern California, and 1 in Southern California. They span 4 years and will enroll over 700 people from the trans community on PrEP.
When CHRP announced an initiative to do a number of demonstration projects for PrEP among trans communities, we were really excited. We knew that there needed to be more research, and we needed to figure out what the best way to deliver PrEP to trans people would be, and we needed to learn that from trans communities themselves.
In the past, I've had a lot of different types of sex partners. I've dated people of many different types of gender identities. In my experience, being on PrEP helps to start conversations around sexual negotiation and sort of sexual risk discussions with my partners. And it's something that I feel like will keep me safe no matter what it is that I choose to do in the moment.
While there aren't any known drug interactions between PrEP and hormones, our project will be monitoring both PrEP drug levels as well as hormone levels to confirm that there aren't any significant interactions.
I haven't experienced any side effects, which is fantastic. For me, it's just sort of something that I've been able to integrate into my daily routine.
I've experienced some upset stomach, but after a month, I'm fine. I don't really experience anything different from what I normally would. And, I'm really interested in seeing what the long-term outcomes are.
Our goal is to connect transgender individuals to experts in transgender health, to provide PrEP free of charge to these individuals, and also to provide the support that's needed to take PrEP every day.
We have a place in this world. Each of us has power, and we have the ability to use that to progress and advance health. So I'm on board, and I think that the more of us that take control of our health, the better off the world is going to be.
The purpose of our state study is to really create awareness and access to PrEP usage within our trans and gender nonconforming communities.
Our job as peer navigators in the state study is to support the community with adherence by providing tech support, adherence counseling, and we have a state quiz to understand your risk for HIV.
New HIV diagnosis rates by age. The next slide is looking at new HIV diagnosis by age from 2013 to 2017. The highest rate is among 25 to 34-year-olds. The rates are mostly stable except from 2015 to 2016, when the rate increased 21% during this period. The decrease seen from 2016 to 2017 is not statistically significant. For 13 to 24-year-olds, the rate was stable from 2013 to 2017. 35 to 44-year-olds had a 42% increase from 2014 to 2015. For 45 to 50-year-olds, rates have been stable from 2013 to 2017. For 55 and over, there was a slight increase from 2016 to 2017, but this was not statistically significant. New HIV diagnosis by age and select race. In this slide, we are looking at age proportions by race. Black and Hispanic cases tend to be slightly younger than white. Black and Hispanic have the highest proportion of cases among 34 and younger. This is represented in the slide by the blue and orange bars. 65% blacks, 62% Hispanics, while 45% were whites. Foreign-born new HIV cases. As you can see in this slide, 23% of new HIV diagnoses in Clark County in 2017 were among foreign-born individuals residing in Clark County. It's important to note that new HIV cases that were born outside of the U.S. doesn't necessarily mean that they acquired HIV from their respective birth countries. 41% of our foreign-born cases were from Mexico. This is not surprising since the majority of our immigrants in general are from our neighboring country of Mexico. 11% of the foreign-born cases were from Cuba, 10% from Ethiopia, 8% from Philippines, and 30% from 20 other countries. The pie chart on the right side of the slide groups the 24 countries into regions, with Mexico being grouped on its own. After Mexico, the next top regions are Southeast Asia, Africa, and the Caribbean.
HIV in foreign-born persons in the United States. As the previous slide indicates, there is a sizable population of folks living in Nevada with HIV who are foreign-born. According to Valverde, they state foreign-born individuals account for 13% of the United States population, but account for about 16% of HIV cases. During 2007 to 2010, a larger proportion of women among foreign-born persons were HIV positive than among the U.S.-born. Heterosexual contact was the primary risk category for new HIV cases in foreign-born men, which was 21%, versus U.S.-born men. The majority of male foreign-born persons' partners were born in the United States, versus the majority of transmission partners of female foreign-born persons who were born in the same world region. In other words, the majority of the male foreign-born persons, their partners were folks who were born in the United States. For people born outside of the United States, women acquired HIV from people that came from the same place as they did, whereas the men acquired HIV from people born in the United States.
New HIV diagnosis by risk and select race. This slide is looking at new HIV female diagnosis by risk and select race. Risk is assigned based on reported exposures. One can have multiple exposures, therefore the CDC uses a hierarchy to assign the risk based on what was most likely exposure to cause HIV transmission. For females, the most common risk categories were heterosexual contact and no identified risk or no risk reported. Heterosexual contact is defined as having heterosexual contact with someone known to be HIV positive or with a person known to be at risk for HIV, such as an injection drug user or someone who may have received a blood transfusion or products in the past. For females, this includes having heterosexual sex with men who have sex with other men. Not identified risk or no reported risk on the other hand, includes persons who reported heterosexual contact with a person with no documented risks for HIV infection of their partners. No identified risk or no risk reported category includes those persons who report no risk because they could not be interviewed. Black and Hispanic females have the highest proportion of no identified risk or no risk reported, whereas white females have the highest proportion of injection drug use. HIV diagnosis by risk and select race. Moving on to males. Male-to-male sexual contact is the most common risk category for males of all races. No identified risk or no reported risk is the second most commonly reported risk category. Similar to black females, black males have higher proportions in this category than white or Hispanic males. New HIV diagnosis by transmission category. This slide shows the risk or transmission category trend for the last 5 years. Overall, transmissions have been consistent, although we see the other category, especially no identified risk or no reported risk, slowly creeping up. It seems that more and more people do not know about their partner's risks. Time from HIV diagnosis to AIDS diagnosis. Next, we are looking at the time from HIV diagnosis to AIDS diagnosis. In particular, we are interested in late diagnosis. Late diagnosis is classified as progression to stage 3 HIV infection or AIDS within 3 months of HIV diagnosis. In this graph, late diagnosis is represented by the blue portion of the bars on the graph for each year. For 2013, 33% of HIV diagnoses were classified as late diagnosis. We can see that the proportion of late cases are decreasing each year. In 2017, 21% of HIV diagnoses were late diagnoses. This is good news and what we want to see. We want to reduce the late diagnosis to 20.8%, an objective set by Healthy People 2020. Healthy People is a set of goals and objectives with 10-year targets designed to guide national health promotion and disease prevention efforts to improve the health of all people in the United States. Persons living with HIV. In the next few slides, we will be looking at persons living with HIV. At the end of 2017, there were 10,079 persons living with HIV in Clark County. 85% of persons living with HIV in Nevada reside in Clark County. However, persons living with HIV makes up only 0.5% of Clark's population. By race, blacks are disproportionately represented, as 29% of persons living with HIV are black, but blacks represent only 11% of Clark's population. Whites account for 40% of persons living with HIV, but represents 45% of Clark County's population. Hispanics represent 32% of Clark County's population, but account for 25% of persons living with HIV. Asian Pacific and Islanders represent 11% of Clark's population, but only 4% of persons living with HIV. Crude rates of persons living with HIV by sex and select race. This slide looks at crude rates of persons living with HIV by sex and select race. Crude rates are rates that are not adjusted for any differences in the group, such as age. Rates are per 100,000 and are race and sex specific. The rate of black males is 2.3 times that of white males and 2.7 times that of Hispanic males. Black female rate is 7.7 times that of white female rate and 9.7 times that of Hispanic female rate. The rate of white males is 1.1 times that of Hispanic males, and the rate of white females is 1.3 times that of Hispanic females. New HIV diagnosis, top 3 types of places met. Next, we are looking at places where in 2017, new HIV cases met their partners. The first text box shows blacks. And the number one places people meet is chat rooms and apps. The number two is clubs. Tied for the third positions are bars, street, and work. Bars are places like Charlie's in Southern Nevada, and clubs are places with dance floors such as Piranha. The second text box shows Hispanics. For Hispanics, the number one site to meet partners is chat rooms and apps. The number two category is bars, and the number three category is clubs. The third text box shows whites. For whites, the number one location is chat room and apps. The number two category is bars, and the number three classification is work.
Sex in the digital age. What are chat rooms, hookup sites, and apps? As the previous slide shows, the number one category for all folks who are newly diagnosed with HIV, regardless of their race, for meeting partners are hookup sites and chat rooms. The terms chat rooms and hookup sites are often used interchangeably. Per the slide, social media refers to mobile and web-based technologies that enable individuals and online communities to share, co-create, social network, and modify user-generated content, which includes words, pictures, videos, and audio. Dating apps and websites differ. Dating websites are generally accessed from a laptop or computer and connect people who reside in the same broad region. Anytime you log on from a smartphone, apps tend to link people in the immediate vicinity, and they provide quote-unquote fast sexual encounters, which require a degree of authenticity, as other social media accounts are required to log on, such as Facebook, and they also tend to be more visually driven. Hookup sites and websites continued. As the graphic on the slide shows, and it states, I hooked up online and I got more than a date. As mentioned previously, as more and more folks are meeting each other online, we're also seeing high numbers of people diagnosed with HIV, but also other STIs, through these websites and apps. In 2015, 9% of the adults in the United States have used a dating app on their phone, which was a threefold increase or 6% increase from 2013. Battle et al. Stated that by 2014, apps had 90 million users worldwide, of which 2/3 were men. Other characteristics from their study found more frequent use of dating apps differed by age, which was mostly 18 to 24-year-olds, low income, and including more casual partners. Other research indicates that men who have sex with men who use dating apps utilize these apps on average 22 times a week, not just for sex seeking, but entertainment and socializing.
Top 7 internet sites and apps. Because online apps are the most common places where people are meeting their partners, here are the top 7 internet sites or apps that were reported. Number 1, Grindr. Number 2, Adam for Adam. Number 3, Craigslist. Number 4, Jacked. Number 5, Facebook. Number 6, Scruff. Number 7, Plenty of Fish. New HIV Diagnosis Top 3 Internet Sites and Apps by Select Race. The top 3 sites or apps are broken down by select race. For blacks, number 1 is Grindr, number 2 is Jacked, number 3 is Adam for Adam. For Hispanics, number 1 is Grindr, number 2 is Craigslist, and number 3 is Facebook. For whites, Grindr is number 1, number 2 is Craigslist, and number 3 is Adam for Adam. Although Grindr was number 1 for all 3 races, the number 2 and number 3 slots varied across race and ethnicity.
STI Screening as HIV Prevention. In this video clip, Dr. Gail Boland, Director of the CDC's Division of STD Prevention, highlights the role of screening for sexually transmitted infections, or STIs, to help prevent HIV transmission. In the next section, we'll discuss HIV and STI connections and co-infections.
Well, in the United States, there are about 19 million new sexually transmitted infections diagnosed every year. That is a huge number. We also recognize that sexually transmitted infections, namely gonorrhea, chlamydia, herpes, and syphilis, can actually increase your risk of HIV. If you're infected with an STI, we think it's more likely that you will acquire HIV if you're uninfected. If you're also HIV infected and have these STIs, you're also more likely to transmit to your partner. We're taking a number of different approaches for reducing the burden of STI. First and foremost, because these infections have no signs or symptoms, individuals don't know they're infected. If they go and seek medical attention, if the provider does an exam, they will find nothing. They need to do a test to be able to identify these infections. So it's absolutely critical that screening, meaning testing someone without symptoms, is one of our main strategies for identifying these infections. Once we identify them, the majority of them are treatable, and therefore we can actually treat the patient and reduce complications in the individual, reduce HIV transmission, and reduce other complications.
Concurrent HIV, STD, and TB co-infections. The remainder of this presentation will focus on concurrent HIV, STD, TB co-infections. Co-infection is defined as having an STD or TB diagnosis within 30 days of new HIV diagnosis. No co-infection means that a STD or TB diagnosis did not occur within 30 days of new HIV diagnosis. These cases may or may not have been previously diagnosed with STD or TB 31 or more days prior or after their HIV diagnosis. In 2017, 108 were diagnosed with HIV and 1 STD or TB. 32 were diagnosed with HIV and 2 STDs or TB. 10 were diagnosed with HIV and 3 STDs or TB. Co-infections account for 34% of new HIV diagnoses in 2017. While this analysis focused on concurrent co-infections, we are seeing persons living with HIV getting infected with STDs as well. 33% of the 2017 early syphilis cases were among persons living with HIV. Persons living with HIV are continuing to engage in unprotected sex because some assume that if their partners are HIV positive, then there is no need for protection with them. Type of concurrent HIV co-infections. The next slide shows the type of co-infection. HIV and gonorrhea and chlamydia co-infection, as well as HIV and syphilis co-infection, are the most common co-infections at 13% and 12% respectively. The next most common type of co-infection is HIV, syphilis, and gonorrhea or chlamydia at 7%. HIV STD co-infections. The next two slides shows the demographics of the co-infections. 97% were males and 3% were females. 60% had anonymous sex. For males, 87% were men who have sex with men. 7% were men who have sex with men and injection drug users. 1% were injection drug users, and 5% were no identified risk or no risk reported. HIV STD co-infections continued. In this slide, the focus is again on males only. Hispanics account for 37% of co-infections, blacks account for 30%, Asian Pacific Islanders account for 8%, and American Indian Alaska Native account for 1%. By age, 51% were 18 to 29 years old, 36% were 30 to 44 years old, and 11% were 45 to 59 years old. Questions. Thank you again for listening to this presentation. You will be able to integrate the information you learn in this e-learning module with other modules which include fundamentals of HIV, linkage to care, and bloodborne pathogens. If you have any questions, comments, or concerns, please contact Angel Stachnik at stachnik@snhd.org.